What is Canada's digital health strategy? Is there a national digital health strategy?
The Canadian healthcare ecosystem is very different from the American. In many ways, our approach to healthcare as well as digital health, we don't really have a national or unified strategy for digital health. We basically run 14 different health systems. So 13 across our 13 provinces and territories, and then one is run by our federal government for military, vets, refugees, et cetera. It's health delivery for those groups. So given this reality, I think what is most exciting, especially in our current climate, is to focus on unification and kind of lifting everyone up to the same level of digitization so we can begin to realize one of the biggest advantages that we'll get coming out of that digitization, and that is access to lots of very good data.
Welcome to the Analyzing Healthcare podcast, brought to you by Scale Community. Scale is a global healthcare-focused member network where healthcare leaders come to connect, learn, share ideas, and shape what's next in our evolving healthcare landscape. To take advantage of all that Scale Community has to offer, from expansive content to virtual and in-person events to interactive peer networking opportunities and more, check out Scale Community at www.scale-community.com. Membership options range from free to paid, so if you enjoyed today's discussion, please take a moment to sign up for your preferred membership level.
All right, welcome to the next Scale Community Technology Innovation and Podcast. I am pleased to be joined today by Anne Forsyth. Anne has spent her career in all things digital health across the Canadian healthcare landscape. She is currently the Director of Clinical Applications for Women's College Hospital and previously spent about a decade as the Manager of Data Standards for the Canadian Institute for Health and Information, among other roles across the healthcare environment from a technology and digital health perspective. So, Anne, welcome to the podcast and very much looking forward to the conversation.
Thank you. Thanks so much for having me. I'm really looking forward to it.
I am excited to get into Women's College Hospital and some of the work you're doing there currently. I'm excited to dig into your prior role at the Canadian National Healthcare Data Strategy Institute or the Canadian Institute for Health Information. But maybe let's begin as we typically do when we're being introduced to a new country's healthcare system with a bit of a macro perspective. And so I would love to begin by just getting an overview of the Canadian healthcare system's focus on digital health today. What is Canada's digital health strategy? Is there a national digital health strategy? What are the key initiatives that are part of that strategy? At a big picture perspective?
It's a great question. I love starting at the macro level because I think it's really important to set the context, and the Canadian healthcare ecosystem is very different from the American in many ways, but also very similar in many ways. So in terms of our kind of approach to healthcare as well as digital health, we don't really have a national or unified strategy for digital health. And the reason for that is we basically run 14 different health systems. So 13 across our 13 provinces and territories, and then one is run by our federal government for military, vets, refugees, et cetera. It's health delivery for those groups. So each of these has their own digital health plans and strategies, and they're also at very different maturity levels. So given this reality, I think what is most exciting, especially in our current climate, is to focus on unification and kind of lifting everyone up to the same level of digitization so we can begin to realize one of the biggest advantages that we'll get coming out of that digitization, and that is access to lots of very good data. So I think there's a recognition around this opportunity across the country, and it's been energizing in the past few years to really see the coalition of the willing come together and solidify some priorities around digital health across the country, even though we don't have a formal strategy. And I think
if you look at a provincial level, is there a strategy? So if you look, I believe you're Toronto, right? So if you look at the Ontario province, does Ontario have a digital health strategy?
Yeah, absolutely. So in Ontario, the way that we are set up, and so again, this is not the same in every province and territory, but in Ontario, there is the Ministry of Health that funds the healthcare system, and they have an agency, a crown agency set up called Ontario Health, where a lot of the funds are kind of flow, and that's where digital health is managed. So for sure, there is a strategy. There are a number of projects that are being run through that organization, and then they work with all of the hospitals across all the sectors of delivery, across vendor partners to deliver on that strategy.
And is it mostly around access to data, or are there particular digital, we're promoting telehealth, we're bullish on telehealth, so we're creating initiatives to increase the adoption of telehealth, or remote patient monitoring in particular specialty care markets is exciting to us, and so we're promoting that? Or is it primarily about, interoperability of data across different healthcare organizations?
Yeah, it's a little bit of all of the above. I think in healthcare, we are not very good at prioritizing, and it's because everything is important and we have to do it all. So there's definitely a focus on things like figuring out interoperability within Ontario, as well as some priority initiatives under that, like making e-referrals happen, e-consults, that kind of thing. There's also, we have a provincial electronic health record. This agency that I described, Ontario Health, is responsible for managing and running large repositories of data, particularly labs data. They kind of bring together a bunch of clinical data in one of their repositories. And so making sure that there is data coming into those, as well as that data being available to clinicians for care purposes. So there's a strategy around rolling that out and continuing to build out the provincial EHR. So it is a very complex and ambitious strategy.
So I'm actually going to go back to your prior role at the Canadian Institute for Health Information, because that sounds like it is a data-driven organization. And then your role as manager of data standards is clearly a data-driven role. So what is CIHI? Is it a national organization? Is it a provincial organization? And what was the mission and purpose of the organization?
So I will just caveat and thank you for pointing out the fact that I'm not an employee there, so I don't speak on their behalf. I just have to say that. But was there for a very long time, and so the Canadian Institute for Health Information, also known as CIHI, is a federal level or pan-Canadian organization. It's independent, not-for-profit, and it exists to provide information on Canada's health systems and the health of Canadians. So I think it's actually one of Canada's superpowers, the fact that we have an organization that's like this, that's arm's length from all governments, and its sole purpose is to receive data, analyze it, and then provide it back to governments, the federal and the provincial and territorial, to help them make decisions on policy, on funding, and also to the healthcare system itself, to help those organizations make decisions on operations and where resources should be kind of managed.
What type of data is CIHI collecting? Is it about wait times and sort of patient experience, or is it clinical? Which utilizers, which providers are high utilizers, low utilizers, high cost of care, low cost of care, outcomes, health outcomes? What's the scope of what CIHI is focusing on from a data perspective?
Yeah, they have a wealth of data and they collect all of that. So their two largest data holdings are collecting data from, one collects data from all inpatient hospitals across the country. And it's like 800 data points. So it's a lot of data on everything from diagnoses to wait times to the actual interventions that were performed on the patient. There's the other large data holding is collecting data from emergency departments, outpatient clinics, day surgery, et cetera. And again, many hundreds of data points and collecting data on similar things, wait times, diagnoses, interventions. There are other data holdings that don't have quite the same breadth of coverage yet, but are getting there. And so those collect data from home care sector, long-term care sector. We're working on primary care. We can talk all about that, and experience and outcomes measures as well.
And what's the method of collecting the data? Is it these healthcare organizations are submitting survey responses, or is it going actual to the claims data at the Canadian Medicare system, combo of both?
Yeah. So for the large data holdings that I described, the data that's coming from hospitals, there is it's mandated that they submit this data to CIHI. And so there is a very involved process that involves taking the data that's documented by clinicians in patient charts, codifying it according to the data standards that CIHI sets, and then submitting that according to very specific timelines that have been established to CIHI, and then they process it, run some data quality checks, and use it for analysis. And so that process involves coders. They're certified and are very experienced with CIHI's data standards. They understand terminology standards like ICD and CCI, that's the Canadian Coding Intervention terminology. And they're able to kind of take what might be unstructured data in a patient chart and really structure it into these codes, these diagnosis codes and intervention codes, so that they can be very easily analyzed downstream by CIHI.
We started off by talking about how Canada doesn't have a cohesive national digital health strategy, and a lot of that was data driven. And yet, CIHI has a pretty good database of data across the country. What does CIHI solve for versus what are the gaps when you mentioned about the data not having a cohesive national strategy? What should we think of CIHI as checking the box and Canada's good on versus what's to come? Or
so in terms of what CIHI currently solves for, it's all kinds of things. It's really become almost a household name these days because we see a lot of media coverage on health-related issues that reference data that comes from CIHI. One of my favorite things that I always like to see reported in the news is what are the most common reasons for hospitalization across the country? And I love asking this question of people because they always miss the most common reason. So I'm going to ask you as well. What do you think it is in Canada?
Slip and fall.
Yeah, that's actually a very common guess, that and heart attacks. But people always forget the most obvious answer, which is giving birth. That's the most common, most common reason for hospitalization. So there's data like that that's kind of very easy to consume and gets reported in the media, and is interesting to the general public to see. And there's also data that CIHI provides directly back to the ministries of health in each province and territory, and that helps them make policy decisions. It also is available to hospitals and other health delivery organizations in the system to help them make operational decisions. And the data is available to researchers for certain purposes.
So sorry, go on.
Yeah, no, I think we were going to flip to the same thing potentially there. But while there is a lot of use of the data currently, there's also a lot of opportunity to grow the use further. So I think that opportunity in particular lives in the research and innovation realm, and making this wealth of data, this huge amount of data that CIHI holds, more available to research and innovation organizations across public and private sector. And that will take a bit of a culture shift in the country as well, because we are a publicly funded system and there is legislation as well as hesitation that exists in making data kind of more freely available outside of the public sector. And so it's something that I think we'll have to work through. And we're looking to other countries, like what's happening with the European health data space, to kind of derive inspiration.
I was going to shift to uses. And so that's, it sounds like there's opportunity for greater use and different types of use in research. But as we talk about current use, over the roughly decade that you were at CIHI, what were some of the uses, both in terms of policy and in terms of performance improvement?
I'll give you one very specific example, maybe a couple, depending on how much time we have. But one of the projects I worked on while I was at CIHI was during the time when opioid usage was really kind of out of control. So we were seeing a lot of visits to emergency departments for opioid overdoses, and there wasn't really a good way to capture this data or identify this data in a timely way. So I said earlier that when data flows to CIHI from hospitals, it's based on very specific timelines that are set. So it's not real time. It flows kind of in Ontario on a monthly basis. In other parts of the country, it's a little bit longer time delay. And so it's difficult to act on that data in kind of an emergency situation like we were seeing for opioid overdoses. And we designed this process where we worked with emergency departments and doctors from across the country to figure out how we can get data on opioid overdoses within 24 hours of a patient coming to an emergency department. It was a very manual kind of flow that we had to design, with literally like yellow cover sheets on top of patient charts so that health records departments can easily identify those charts and take them down to the coding department, get that data into CIHI overnight, and then we would have it the next day. But, it was to kind of tackle this emergent, very important crisis that our emergency rooms were seeing. And it was to identify where these patients were showing up, which emergency departments, and then make sure that we have the correct resources in terms of the actual medical intervention and then the health professionals available and staffed at those places.
So it's real time data at CIHI. I mean, I'm thinking in the US, I'm drawing a blank on the acronyms. I think it was like PQRS, but it was an annual submission, voluntary submission of, or mandatory, but sort of user driven submission of data at different healthcare facilities. But it was annual. And so, once per year, you might get the report of the key findings across the country. But CIHI sounds like it's set up not just for the longer term trending, but also real time insights.
I wouldn't say real time yet. I think they're hoping to get there. So the deadlines are annual. What some provinces like Ontario have done is set kind of shorter deadlines. They're more guidance. And so those are monthly, some are quarterly. So that helps get it earlier data faster. But no, I think there is actually a lot of opportunity for real time data to flow, especially now that we've really moved the needle on digitizing within our health delivery organization. So adoption of electronic medical records.
Any other interesting case studies, success stories beyond the opioid, or is that the main one that stands out?
That's the one that always stands out in my mind. But another one that I always thought was really cool was when we started to introduce kind of new funding models within Ontario, very similar actually to the value-based funding that you have in the US. And so we started to look at how we can look at bundling up funding so that the money follows the patient all the way through the system. And it's not just this money is going to the hospital and then we kind of lose track of the patient. And so for very specific cases like shoulder surgeries, hips and knees, we attached, or the government attached, funding for care from surgery all the way through to rehab. But there was no way to kind of track the patient through all the organizations that they would go to. So CIHI stepped in and was able to provide the means for that, the data holding for that. And that was kind of also attached to outcomes to see if, the amount of money that's attached to each patient is also giving you good outcomes, good experience. So I actually didn't see the project all the way through to completion. I shifted roles at CIHI, but that was another one that is a good demonstration of how data can be used to also inform funding decisions.
Who are you partnering with, or who were you partnering with at CIHI? Is it, I imagine you have a counterpart like a CMS, like Center for Medicare that we have here in the States. Is there a body that's setting the regulatory reimbursements and guidelines?
Yeah, so reimbursement or funding is all within the realm and responsibility of ministries of health. And those are the main, I would say, customers or stakeholders for CIHI. So those are the groups that we worked with most closely to make sure we were meeting their data needs.
Interesting. Very interesting. I don't know if you have insights into this because it's a complicated question, but given that you have all this data that sounds fairly well organized, were you able to get into comparisons of Canada's healthcare outcomes versus other countries? And if so, I'd be curious where you think Canada excels, and maybe areas where you think Canada has opportunity for performance improvement relative to other countries.
So we didn't explicitly put out reports that compared Canada to other countries by CIHI, but I think a lot of the data that they hold gets used in reports that compare OECD countries. In terms of where Canada excels, I think for sure I'm going to just do a quick history lesson and go kind of medical broadly and healthcare broadly rather than just data. I actually think there's a lot of really cool innovation that's happened in Canada, a lot of interesting breakthroughs that have happened here. And I say this because I think it's so important to ground ourselves in that, because we do need a bit of kind of push to get back to that more innovative mindset in Canada right now. So, everything from insulin being discovered here to the initial discovery of stem cells and the world's first external artificial cardiac pacemaker. Those are all innovations that have come out of Canada. And then I think in more recent times, what we're kind of known for is the work that Jeffrey Hinton did on neural networks that kind of paved the way or the scientific foundation for AI. So, in the field of medicine and innovation, there's been a lot of really cool work that's happened. But after COVID, like every other country, I think it was, there's been kind of a lot of factors that are putting burden and weight on healthcare systems. And that's, a lack of health human resources, increase wait times, difficulty accessing healthcare. And, we kind of, if you look at the Canadian healthcare system and its publicly funded nature versus privately funded nature, I still think there's a lot of good that comes out of that we should remember and pair up with all this cool innovation that we've had in our history. And so, for example, our patient safety standards are very high. Our outcomes are quite good. And our life expectancy is pretty high. Our methodology for evaluating our performance and making sure our hospitals are meeting high quality standards is really, really strong. So, while there's lots of room for improvement, I think there are so many wins that we can kind of keep drawing inspiration on to get through this more tumultuous time that we're all kind of facing.
So maybe shifting gears now to Women's College Hospital. You have now taken a role for the past two years as Director of Clinical Applications. So what does that entail? And at a micro level, so a specific provider-based organization here, how are you thinking about the use of technology and applications in advancing care delivery for Women's College Hospital?
So when I took this role, it was a very deliberate shift away from government into a health delivery organization. So I think I spent probably about 12 years avoiding working in a hospital because I was always intimidated by the pressure that's involved in the kind of pace. And I got to a point at CIHI where, I'd worked at the provincial level in government and then at the pan-Canadian level with CIHI. And we were always talking about we need to enable interoperability. If everyone could just adopt data standards, like data would have meaning and it would flow and we would be able to do all these really cool things like, building a learning health system for the country. But we never seemed to be able to fully crack the nut and make the progress that we needed. I never understood why. I'd sit in these meetings with representatives from ministries and they would say things like, oh, you don't understand clinical workflow and the nuance there. And so when you set data standards, it doesn't take all of that into consideration. So I left CIHI to come to a health delivery organization, to a hospital, to really understand that. And I was lucky enough to land this role at Women's, which is a hospital that runs the Epic EMR system. I really wanted to understand that as well. And I will say in the past 2 years, it has been completely eye-opening for me where those gaps are. And I totally get it now, what everyone was saying in those meetings when they were explaining how nuanced clinical workflow is and how much standardization is needed there. Because that's the point at which data is first created in the healthcare system. And we rely on our clinicians and our, the frontline staff to create health data, which is crazy because that shouldn't be their main job. They're providing care to patients. But we have these expectations of, we're going to get this beautiful standardized data and structured data from people that are supposed to be saving lives every day. So that's kind of been my high level learning from coming to Women's. And I'm happy to kind of give you some very specific examples of
these would love to hear.
Yeah.
How big is Women's College Hospital in terms of number of sites, number of patients?
So it's one site. We are an ambulatory hospital, so we don't have inpatient beds and we don't have an emergency department. We have about 40 clinics that do about 300,000 visits a year. So it's interesting because outpatient or ambulatory services is an area that many hospitals kind of not ignore, but they haven't necessarily put digital strategies in that space. They kind of focus on their inpatient first. And what we've done to standardize workflow across Women's is something that I think could be useful to hospitals that are now turning their attention to, we have our EMR in inpatient. What do we do with it for our ambulatory clinics as well?
Yeah, would love to hear some case studies of what you've been focused on from a digital perspective over the past couple of years.
So I'll tell you first, where our inspiration kind of came from. Our focus is optimization and standardization. And the standardization is really to get at that good quality data because we want to be able to use it. We're also a teaching hospital, so we have an academic institution and research is a big part of what we do. So we want to be able to have access to good quality data for research purposes. And so in terms of the inspiration behind all of this, for me anyway, was going to one of the Epic UGMs just a few months after I began in my role and hearing Judy, who's the founder and CEO of Epic, speak at her keynote address. And she made this comment that I loved. And she said, you have to know where you have invested your money in technology and use that technology to its fullest extent. make sure that it's fully optimized. So don't go out and like bolt on different things to solve a problem that appears to be just the immediate problem in front of you. Try and get to the root cause of what's going wrong and then use what you already have. So we've kind of been on this journey of diving into all of the cans of worms that no one has ever wanted to open. We've had Epic for 10 years at our hospital, and it's about the time when hospitals with this EMR system start to become really unstandardized in their workflow. So this is when users, clinicians will find ways of just getting stuff done just to get through their day, but it's resulting in, charts that aren't being closed because they want to avoid a hard stop that's been built, or data is just like being put in places where you wouldn't expect it to be. And so we've had to take a very kind of methodological approach to identifying our problem areas and then fixing those. The example that I'll share with you is we're trying to create a standardized operating procedure for our registration, check-in, and arrival workflow right now. And that is a lot of people see it as kind of low-hanging fruit. It's easy to solve, but it's been a journey for the past few months, because the way that, again, our medical secretaries interact with that portion of Epic is very, very different across the board. So there's a lot of change that's involved in moving people's habits to what the right way should be. With that particular workflow, registration, check-in, and arrival, we kind of took a look at our data first and what we wanted to do with this whole thing. There are lots of hospitals that are kind of jumping into, we need a digital front door. And we really wanted to understand, like, what does that mean in our hospital? So we looked at our data and we saw that our patients are super digital. They're actually very high. We have a very high usage of our patient portal that comes with Epic. Almost 70% of patients are using it completely unprompted. We don't advertise it. We don't ask people to sign up. And so we saw that as like a really good opportunity to move some of the, I'll call it, burden of data collection over to the patient, rather than having that data collection happen when they arrive at the hospital by a member of staff. And so we designed a whole pre-e-check-in process that takes place in the portal for the patient to complete before they arrive. We have notifications going out to the patients by email so that they know exactly what they need to do. And we've been piloting this for about 3 months now in a few different clinics, and we've seen really good completion of the data set that we identified, really good uptake by the patients in completing this process, and then they understand exactly where they need to go when they arrive. But the one outcome that we've seen that's been so exciting and a completely unexpected fringe benefit of this is a reduction in our no-show rates. So something about people interacting with the hospital digitally before they come to the hospital for their appointment is encouraging them not to just cancel. Like they somehow, they feel an attachment to us and they show up, which is great because we bill when they come.
So are you building any proprietary applications on top of Epic, or is this primarily about just aligning workflows with utilization of the pre-existing system?
Exactly. Yeah, exactly. It's taking Judy's message of like using what you have. So we have just optimized the way Epic has been built so that patients can very easily complete the data points that we've identified. We incorporated some features that we didn't have with Epic so that our medical secretaries can very easily see when a patient has completed what they needed to complete. There's literally a giant check mark and it says respect the check. And so it's like if they have a check mark, the patient has done what they need to do. You don't need to re-ask these questions. And so it saves a ton of time. So it's taking all of these features that existed and just optimizing that work.
Last question, just sort of taking a step back, you've had a chance to work at CIHI on the government side, at Women's College Hospital now on the provider side. And I didn't mention this, but you were also at a EHR prior to CIHI. And so you've seen government, provider side, technology side, and you've been focused on data across all these roles. And so I'm curious with that perspective, as you've gotten to know how each organization thinks about data and what each organization's needs are and realities are, constraints are, what are the biggest gaps between those three segments, technology, service provider, government, and provider side, that if you were sitting in one of those seats and you were sitting at CIHI asking something of the Women's College Hospital, do this differently, or please understand this because of the bigger picture, what would that something be?
That's a really interesting question. I feel like you're asking me to sum up 15 years of experience in like one shot. I would say my biggest takeaway from kind of going across all of these different organizations has been this observation that every organization I've been in is very kind of married to their perspective and their experience. And if only a government would understand the way it is in hospitals, or if only hospitals would understand how important this data is at a pan-Canadian level. And I think that the most important thing is for all of these organizations to collaborate more openly and more with a greater understanding of the value that each perspective brings, and recognizing that your perspective is important as well. With interoperability, it's a complex thing. It's something that we're trying to solve across the country right now, and we have vendor partners, government, organizations like CIHI, all trying to attack this problem. And the only way that we'll actually be able to solve it is if we do kind of respectfully take every perspective into account, and design solutions that work for everyone. It doesn't force technology partners into huge losses because now you have to rebuild your whole architecture to meet certain standards or something like that. It's not, you're not going to get to the end point that you want to be at if that's kind of the forced mandate that you're trying to push.
Now that you've gotten to know some of the realities of implementation of technology, utilization of data on the provider side, is there any advice that you would have back to CIHI in terms of how they're thinking about data aggregation and in terms of how the government is using data to drive policy and performance improvement?
Yes, I think not just for CIHI, but across the healthcare system, the biggest kind of gap I think we still need to close is digital and data literacy. It's relatively newer in healthcare that we've digitized, we've moved from paper to this digital world. And I don't know that our medical education and training has kept up with that shift. They're being trained on how to be good clinicians, not how to use technology and how data flows across the system. And so the impact of their documentation and what that means downstream for organizations like CIHI. So I think there's a lot of really good work, creative work that we can do to increase that literacy without, obviously making it the main thing that we're trying to teach clinicians, because that shouldn't be the main thing that they focus on, but have an increased awareness of it. There's some maybe scary things that can happen when standardized workflows aren't followed, assumptions or data points that get lost. And when that starts to flow in large volumes up to a provincial level or a pan-Canadian level, you lose a lot of the insight that you could have gained from that data. And so having that confidence that the quality of data is high right from its point of creation all the way through the flow of it through the system, it's, I think, the only way we'll be able to fully rely on that data. So yeah, I think at all levels we can do a better job of increasing data and digital literacy.
And I really want to thank you for your time and for the introduction to the Canadian healthcare system and Canada's digital landscape and a little bit of the history. I really appreciate it. So thanks so much.
Thank you. Thanks for all the great questions.